the 12 rules to live by on testosterone. This is rule number 7, estrogen and its effects. It's going to be a big video because so many men have contacted me and my staff over the many years saying that they just want to talk about their estrogen and the imbalance of estrogen. And I agree, but this is something that goes beyond science. It's such a clinical manifestation here, everything I've learned. We all know, everyone knows, that testosterone endogenously, and for this discussion, exogenously, is going to convert, aromatize into estrogen, which is estradiol, mainly. And I'll say, right off the bat, let's talk about this from a general clinical perspective. Don't blame and hate too much on estrogen, guys, because we know that over the last 20 to 30 years, we know it's so sensitive. We know the balance is important, but we see that there's such fundamental aspects to the testosterone experience in a positive way in the limbic system that men feel so well. And that is in mood, sex, and well-being overall. And we know that it's not just straight signaling from androgenic signaling. We know that. There's this mix of estrogen. We know it. So when you block it and you just block it on paper with AIs or even selective estrogen receptor modulators, which we know doesn't affect systemic circulation, but it affects more local, that men just don't feel right. I can't tell you, this is so, it's so significant, but it's so intangible. You can't touch it. There are no studies on this. That's why I'm speaking. This one today is really more from my heart, if you will, and from the thousands of men that I've worked on in looking at their clinical experiences on different drugs, mainly testosterone. This is mainly for TRT guys on this one. And looking, of course, correlating about on the labs, their estrogen, their numbers, and then using different drugs to block. So I can tell you that it's going to be very important every man to understand what he's doing and what he's looking at, and not to just hate on estrogen and block on estrogen with these medications that are out there that are utilized widely. So I want this to be known. But why don't we take it from a systems approach? Let's look at it very pointedly and very specifically from that experience that I have from head to toe. Number one, the first systems that will hit is the mood, the CNS. There's going to be mood changes when you're on testosterone. The estrogenic component to that is fundamental. And again, there's no specific data. Anxiety can happen, depression, moodiness.
Hey guys, quick pause here. If you're watching this video, odds are you're concerned about your testosterone levels. That's where the sponsor of this video comes in. Let'sGetChecked.com. Let's Get Checked makes professional health testing easy by letting you get tested without having to visit a healthcare provider. Choose your test online, like one of their testosterone panels, and it will be delivered to you in discreet packaging with next day delivery. Once your sample arrives in a laboratory, confidential results will be available from your secure online account within 2 to 5 days. See my link in the description for more details and discount code.
Anxiety can happen, depression, moodiness. I've heard countless men tell me that they're better husbands. They're on testosterone. We look at the estrogen, that it's slightly elevated in that range for ultra-sensitive estradiol. I'll talk about this in the end, technically, on a liquid chromatography mass spectroscopy range, where I like in America, North America, to see that range where it's less than or equal to 29 picograms per milliliter. So you look at men and they have elevated superphysiologic estradiol, and they'll tell me that doc, I'm a better husband, I'm a better lover, I'm a better father and I'm a better coworker. I'm more outgoing and I'm more social. I can't tell you how many thousands of times I've heard this from men. And then we look at the number and we say, wow, it's super physiologic though. What do? Use the blocker, lower the testosterone? Stay with me on this. I want you guys to understand it from my perspective. But on the flip side, the moodiness, if you will, when you start a man on testosterone, and this can be creams and gels and pellets and really anything, but this is fundamentally more about the injections that we use, right? Everyone's going to, in the end, boil down to using small microdoses, right? So you could see outright anxiety. You could see frank, severe, even panic attacks. And again, this is looking at estrogen, keeping it perfect on paper, mostly without aromatase inhibitors, and we're going to get more into that. Last night on the app, we had a great discussion. We had men on the app, and we were talking about TRT and anxiety. You want to come in the app, guys, you want to check this out. And we talked about one man who is trying to find the balance and even utilizing antidepressant medications like Zoloft and Wellbutrin and other medicines. And one man felt great, one man didn't, one man's still finding his way. So that goes to show you that this is super complicated when it comes to the mood aspect of looking at the estrogenic component of men that are on TRT. And the caveat stands for just looking on paper and blocking estrogen, looking the other way, as I say, and using those AIs again. Next system is the sexual system. So this can be outrageous, where it's great, or it can be outrageous and it's bad. Even tiny doses of AIs can just crash the estrogen and crash the sexual experience. I want to tell you a story. Probably 12 years ago, writing in the magazine, some of the bodybuilder guys came in, mostly amateur guys, but big boys. And I had a young guy come in his 20s, and he's on steroids. He's on about 500 milligrams a week of testosterone esters, and he was on Dianabol. And I remember I was looking at my computer, looking at his testosterone and estrogen levels and different things. And he's sitting, and he's not looking at the computer. He's sitting in front of me, and I'm looking at him peculiar. He goes, "Doc, what are you looking at?" I go, "I'm just looking at this stuff." Meanwhile, I'm learning. I didn't really know this. This is 12, 13 years ago. I was trying to learn it all. Calling different anti-aging doctors and calling other. When I realized calling endocrinology physicians really wasn't any help to me, I kind of said, well, I'm kind of back to the drawing board with this. So I just have to learn from the guys in the streets. It's really true. So I go back and look at the guy's numbers and I say, "Sir, I got a question for you. What do you got, Doc? What do you got? How's your sex drive? How's your sex?" Because I've seen some guys already, we're looking at these numbers, his estrogen was off the chart, just so high, I don't even remember whatever scale I was looking at. It was just greater than, it was just off the chart. He's on testosterone and Dianabol, these are severe, both of these are estrogenic drugs, and he's on a lot. So I'll never forget that he said, my sex, doc, sex, it's awesome. My sex is great. Should it not be great? Sex is great. Estrogen looks outrageous. It's off the chart. I'm thinking the sex shouldn't be great. I should use an AI or lower these two. Absolutely unbelievable. See that? Men use steroids, estrogenic steroids. Numbers can be off the chart. Estrogen's off the chart. You ask them, how do you feel? They feel great. Well, shouldn't it be blocked? This is when I started realizing we have to be careful with all the blockers. System number 3, probably the most important for this video, gynecomastia. Estrogen and gynecomastia. Here we go. So even small doses of testosterone replacement, baby doses, gel doses, pellet doses, can cause 2 types of gynecomastia. Sensational, where you feel the burning and it's annoying and it's really uncomfortable. And you have physical masses, where you have actual mass. You have a mass. That's the gynecomastic mass. I'll always tell you that it has to be ruled out for breast cancer. With the grace of God, I've never seen one case of breast cancer on a steroid user or a man on TRT. We're talking thousands of guys. So that's good news right there. But I don't want to see my first case. So if you have gyno and masses, lumps, you want to go see a doctor to get evaluated with that. That's always going to be smart advice. What do you want to do with a gynecomastia? I want you guys to have information here. So use microdosing. Do not use aromatase inhibitors if possible, but I understand some men need them because they use the smallest dose of testosterone they can, and they like to run a little AI with it. I would say take, if it's anastrozole, use 0.5 milligram or even 0.25. I love those 0.25 caplets that compounding facilities can make, and you take them sparingly. A lot of guys say, you know, doc, I use it sparingly. I feel a little, I use a little, I use it once a week or twice a week and back off. Please don't use 1 milligram or even 0.5 milligram of anastrozole every other day or 3 times a week or even twice a week, just running it forever. Please don't do that because you're going to crash your estrogen. Everyone knows that. Well, a lot of guys learn that. So the next is be careful, but can use selective estrogen receptor modulators, tamoxifen and raloxifene. Tamoxifen 10, 20 milligrams. We know that. Again, sparingly once or twice a day. Raloxifene once a day, 60 typically. They're medicines that you don't want to live on them, guys, but can you use them sparingly to knock down the sensational aspect of gynecomastia, mostly the sensational aspect, but some of the masses. And lose weight. We've seen that men that are heavier, that are overweight and heavier, they will aromatize more than when they're lean. So it's a good excuse to lose weight. I'm giving everything to you guys on this. Creams and pellets will also cause gynecomastia. Seems like a lot of anti-aging doctors and doctors will say, well, you're not going to have gynecomastia if you just use this pellet or this cream. And that's not true. And the last part is use this carefully. And in the end, go see a great plastic surgeon. I say it every day. Okay. System number 4, going down the body, if you will, cardiovascular effects. The obvious effects of aromatization is an increasing circulatory estradiol is going to be water retention, hypertension. So it's, you know, when you look at the cardiac effects of steroids and testosterone, this is really my day job. I do it all day long. And probably the most important thing I do is protecting men from the cardiac events because I'm an internal medicine doctor. So it just kind of comes naturally with or without the medicines is that, you know, secondarily versus primarily, if you have, is it directly causing coronary artery disease or is it secondarily causing cardiac disease? Anything that causes hypertension, I don't care if you're eating poorly, too much salt, going to McDonald's, and you end up having hypertension, that causes vascular disease, coronary disease. So if you're on too much testosterone for too long, imagine and you're systemically hypertensive, that's going to end up hurting the heart. Common sense, guys. Common sense. Also, it's amazing. Get the thinking caps out for this. So the estrogen itself component we know is positive for HDL, that's a positive chemistry on a lipid panel. You want to have HDL high, like you see in healthy women and healthy young men too, of course, some men. And then you see the HDL going low on testosterone. We see that, but not always. And the estrogen's playing a big role. If you use aromatase inhibitors, it's almost guaranteed you're going to see the HDL go into the tank. And again, you're starting to get into dangerous scenarios. Blood pressure is not great. You've hurt the protection of the HDL. You see what I'm doing, guys? You're adding up. The moons are lining up. Chunk, 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 chunk. You have coronary disease. It's unstable. Chunk, boom. You have to look at that from that perspective. So again, the cardiac effects for estrogen without blocking may be positive. I'm not saying we know. There's no direct data for that. You look at women's health, heart health and things when they have estrogen in their younger, middle age versus when they get older and they lose it. There's enough data, you know, that you can think of, well, do you really want to wreck estrogen and block estrogen on this? so much. This is just caveats for you guys. The endothelial effects with testosterone mediating with supraphysiologic estradiol, hypercoagulable, blood clots, DVTs, pulmonary embolisms, myocardial infarction, and so on and so forth. This is where it's super complicated. Please take a minimal effect. Please take a man-to-man effect. Please get the calcium scores. Check your blood pressure. Check the family history. Be vigilant on that. Check the sugar, the A1C, the blood pressure. Do all this and use protective medicines, guys, if you're going to enjoy testosterone. It's not going to be an easy dance. The anti-aging guys, I wish they would look more into the heart aspect just by giving testosterone and blockers and kind of letting you guys take whatever you want. When I see men come to me, when I do a calcium score and they have significant plaque in the artery, that's a no-brainer to me, guys. System number 5, prostate system. We're moving down. Less is known, right? Everything else I talked about, gynecomastia, even the heart stuff, a lot is known. Less is known. They're interesting endogenous data, though. When you look for men that are older versus the prostate, on the prostate, men that are older inherently will have lower levels of testosterone, higher levels of estrogen. And then we see older men are at risk for prostate disease and cancer, prostate cancer, and even BPH where it enlarges. I want you to really think, there's no long-term studies on this. There's no data for this at all. So I want you to really think, though, if you're on TRT and you're super physiologic with estradiol, regardless of the testosterone being higher, in a relative fashion mathematically, what are the effects going to be on the prostate? The prostate, I see guys that are on testosterone for decades, and with the grace of God, they're probably doing well. Some of these guys, most of these guys I see and I take care of, do the best I can. I see their prostates are enlarged. And again, no cancer. We already have videos on the cancer, right, about prostate disease and testosterone. But this is the estrogen side. So what do we do with that? I wonder myself, should we be monitoring and keeping ultrasensitive estradiol itself to a certain range for outcomes for prostate health? This is cool stuff. Would it be smart to use AIs? We don't know. Boy, you talk to me in 20, 30 years, this is going to be information maybe someone's going to come up with. Last but not least, those are the systems. Management techniques when you're on testosterone regarding the estrogenic side effects and your estrogen in the systems. Microdose. Again, you could use gels and pellets. You can use nasal testosterone. You're always going to have to consider some aromatization. Microdose, small doses of small injections of cypionate and nanthate, and over there in Europe, love the European guys, Sustanon 250, great medicine. Baby doses, and then you could look at ultrasensitive estradiol. Please try to keep the aromatase inhibitors to a down low. Use them sparingly. You can use them sparingly. Think about the effects on all the other systems, the mood system, the heart system. Keep it limited. Selective estrogen receptor modulators. I told you about tamoxifen and raloxifene. You could use them. I gave you the doses even. Be careful. It's medical information. This is not medical advice. So be careful with that. Try to keep things sparingly. Try to keep things where you're not staying on them for too long and you're looking at your data, working with a good doctor, someone like me that's a primary care doctor based and trained, and they may not know everything. Maybe endocrinology guys, no one knows everything. I certainly don't. Work with plastic surgeons. If you don't like your gynecomastia, go see a surgeon. Get those masses checked out. If you want to talk about the technical side, do not check total estrogen. Do not check total estrogen. It's a waste of time. I've seen 4,000 levels, and then I've seen doctors and patients use more aromatase inhibitors, and it doesn't even change the 4,000. It gets worse. I saw this decade or so ago, and I realized that total estrogens, the assay, are terrible. They can be contaminated with other assays, other agents and constituents. They're horrible. Ultrasensitive estradiol, liquid chromatography, mass spectroscopy, it's a dilution method. Please use that. ultrasensitive estradiol, if you're going to measure estrogen at all. Supplements, yeah, DIM can work. It's like a weak aromatase inhibitor. I don't really know. Can you add HCG? Be careful. HCG, obviously, for the testicles and fertility. We talk about that. I've already done videos on this thousands of times. I've made statements. If you add more HCG or a medicine that's going to increase your endogenous testosterone, it's going to be additive to the exogenous testosterone, and you could aromatize more. Again, everyone knows this who's in the streets of the worlds of the bro science and the guys that are on this stuff, but a lot of you guys are brand new here. I want you to understand that. Just adding HCG for your testicle atrophy, you can do it. Does it work years later? Can you keep up the doses? I don't know. You also have to keep in mind, there's no data for this. No, I'm a scientific guy. There's no data, so I have to tell you guys what I've seen with thousands of men. HCG, guys get estrogenic. If you're on testosterone, maybe you could lower your testosterone dose to make up for the small dose of HCG. That's a secret technique. Just be careful. And adding clomid, that's the last question, the last that I get. So many men, if you're on testosterone, I don't see any need to add clomid unless you're trying a PCT cycle where you're going to be coming completely off testosterone and you're going to run tamoxifen, clomid, and HCG, classic, right, Llewellyn PCT, which in my opinion doesn't hit the reset button and change your brain, but it could help men feel better, and it's up to you, right? This is all information for you. Because there's no conclusive data, so we have no data. We have no books up here. Hey, see the books? See that? Internal medicine, cardiology, books, a lot of information there. You're not going to find this in any books. This is just going to have to be man per man. You have to be careful. You're doing it yourself. I'd love to help you guys. So I'm giving you the experience with this. Adding clomid to TRT is just a mess, and no one really who knows what they're doing does it. I mean, what are you doing? HCG they have, but not clomid. And even on clomid by itself, you get estrogenic. Estrogen goes up using clomid. It's an anti-estrogen, but your estrogen goes up because it's an anti-estrogen in your brain, and it stimulates the endogenous production of testosterone that will further then, therefore, aromatize. Thank you so much, gentlemen. Thank you so much for enjoying this. I hope you do enjoy it. Comments, bust them open. I want comments from everyone. I love it. This is going to be a huge video because so many men care almost more about anything about my estrogen. Thank you so much, gentlemen. I hope this helps everyone. Thank you.